Welcome everyone, and thank you for participating in today's Get the Medications Right Learning Network webinar, How to Integrate Clinical Pharmacist into Primary Care. My name is Katie Capps, and I'm co-founder and executive director of the Get the Medications Right Institute. On behalf of the Institute, we are delighted that you're joining us today. Now, before I turn it over to our expert presenters, I'd like to provide a little bit of background to set the stage. The Get the Medications Right Institute is a multi-stakeholder coalition formed to bring together critical stakeholders, all bound by the urgent need to optimize outcomes and reduce cost. GTMRx works to enhance life by ensuring appropriate and personalized use of medications and gene therapies. In order to do that, the Institute focuses on 4 key areas: practice and care system transformation, payment and policy solutions, precision medicine via advanced diagnostics, and health IT to support optimized medication use. We invite you to join our work if you're not already participating in the work of the Institute. Now, the work of the Institute is necessary to address challenges to optimize medications from today's healthcare landscape. Increasing medication complexity is among those challenges. There are over 10,000 prescription drugs available in the U.S. market today. 80% of patients leave their primary care provider office with a prescription. Medicare Part D beneficiaries also have an average of 3 to 4 prescribing physicians. That means nearly 30% of adults take 5 or more medications. That leads to over 4 billion prescriptions being filled annually. But primary care providers only have about 49 seconds in a typical 15-minute patient visit to talk about new medications. If you consider these facts, it's no surprise that suboptimal medication regimes and subsequently poor patient outcomes are all too common. Adding to the challenge of medication complexity is our nation's primary care physicians that are overburdened. Primary care physicians see an average of 20 patients a day, and after each visit, an average of 16 minutes is spent on the electronic health record, including things like chart review, documentation, ordering, etc. These and other increasing demands and limited reimbursement for primary care, plus less time with patients, contribute to a negative impact on physician well-being. Recent data supports that over half of practicing physicians are experiencing substantial symptoms of burnout. Ultimately, we have a healthcare system that is fraught with the negative consequences of non-optimized medication regimes. That leads to $528 billion a year of annual waste. And that waste is attributable to additional hospitalization costs, long-term care admissions, emergency department visits, provider visits, and additional prescriptions. It also translates to over 275,000 lives lost a year due to non-optimized medications. Now, it's important to note that these outcomes are the result of a wide array of medication therapy problems. This goes way beyond medication adherence. Medication therapy problems include inadequate therapy, adverse reactions, the dose being too high, or unnecessary therapy. At the Institute, we believe the solution is a service called Comprehensive Medication Management. CMM is a systematic approach to optimizing medications where physicians, qualified clinical pharmacists, and patients collaborate to get the medications right. In April, the Institute asked healthcare leaders to give us insight into the current state of medication management. I think some of these findings will help set the stage for today's discussion. When we queried healthcare leaders, 50% of those that we polled said that the lack of communication between prescribers and pharmacists is the biggest issue with managing medications. Now, we were surprised that the answer was chosen more frequently than cost of medications. In fact, cost of medications came in at 36%. In that same survey, we asked what the first step should be to change the way we manage medications. The top 3 answers, which were all closely ranked, were physicians working in collaborative practice with pharmacists to help patients reach their clinical goals of therapy, access to clinical information at the point of care for all team members working with the patient, to include the clinical pharmacist, and this clearly has a health information technology solution tied to it. And then finally, payment for CMM services. More than half, or 61% of those surveyed, also believe that making a medication coach part of their team to evaluate all medications and create a custom plan for them to easily and safely take those medications and then help them understand any potential side effects or needs for change of the medication would be very helpful. Now let's keep those findings in mind as we go into our discussion session today. Now let's get to today's presenters. I'm delighted to introduce to you today Dr. Peter Teichmann. Dr. Teichmann concurrently completed his MD and Master's at Michigan State University. He completed the family medicine residency at Brown University and the Harvard University Macy program on improving medical education. Dr. Teichmann's many peer-reviewed publications have provided practical tools for providing safe care through clinical challenges, including authoring the first nationally published medication use agreement for managing opioids. He's also co-authored the article, How to Integrate Clinical Pharmacist into Primary Care. This was published with his co-presenter today, Dr. Wan. That was published in the American Academy of Family Physicians FPM Journal. The article discusses barriers and opportunities for reimbursement of CMM level services in team-based care. In addition, Dr. Teichmann is a full-on clinician while also helping to develop safe and efficient IT solutions that reduce clerical distractions and increase immediate decision support so clinicians can maximize their face-to-face time with patients. He helped develop family medicine education and training programs in Hangzhou, China. Dr. Teichmann also practiced medicine and lived for years in Vietnam with 2 goats, his 4 sons, and 9 dogs. After Dr. Teichmann's presentation, we'll hear from Dr. Shaowei Wan. Dr. Wan is currently the T32 Research Fellow in Palliative Care and Aging at the University of Colorado School of Medicine. She earned her PhD degree in Pharmaceutical Health Services Research from the University of Iowa College of Pharmacy. In the past 6 to 7 years, she's been teaching in the Professional PharmD program on the subjects of healthcare systems and policies and pharmacoepidemiology. Her research interests focus on health disparities and the team-based delivery model. Dr. Wan has studied interprofessional team-based care in the rural setting and taught interprofessional team-based practice competencies to PharmD students. She is a strong advocate of integrating clinical pharmacists into the team-based care delivery model in our healthcare system. I want to thank both of you for joining us today. And with that, I'll turn it over to Dr. Teichmann.
Thank you for saving my life. I have one of the best jobs in the world because from time to time, I get to hear that statement. Thank you for saving my life. Though I'd like to think that I earn my Superman socks every morning when I put them on, I have to be honest with patients when they say that to me. and tell that I'm just one link in a chain of people. I'm just one member of a team. And one of the most important members of that team are clinical pharmacists. And I think that our needs are such that clinical pharmacists need to come forward and be there for patients and bring their skill set. If they do, they will also be able to hear, "Thank you for saving my life," because what they do is so important. The needs are high. We can talk about all the statistics and how much money is lost. We can talk about how many errors occur. It's difficult to wrap our heads around it. But I want us to think about two easy numbers. The numbers are 4 and 400. 400 billion. 4 is for 4 years. It's the amount of dedicated time and medication management that pharmacists pursue in their education and training. No one comes close to that. As a doctor, I have not received 4 years of dedicated study in medication management. 400 billion is the cost of prescription-based medication in the United States per year. Okay, give or take a few billion, I'm not sure exactly. We need to match up those numbers. 400 billion, that's our investment. That can cover a whole lot of need. We can do it right, or we can do it wrong. There are plenty of things we're not doing right now. We should not let go to waste that wonderful resource of professionals who've had 4 years of dedicated training. And when Dr. Wan and I wrote this article, our goal was to bring these numbers together, to bring clinical pharmacists directly into patient care, to bring their full effort and responsibility to the need. When we wrote, we weren't just writing theoretically. We were writing about actual practices and the practical aspects of providing care. I know it works because I've worked with clinical pharmacists for years. I hope others will get the opportunity to work with clinical pharmacists. Before I pass on to Shaowei, I wanted to thank Katie for the great work that her institute is doing. It's so important. And I really thank you for the opportunity, the invitation to, instead of working parallel with you, to join forces and to do this good work. I wanted to thank Dr. Shaowei Wan for her contributions. As a young scholar in Beijing and Tokyo, I don't know if you ever had the vision that you would someday be contributing to improving American healthcare, but I'm sure glad you are. So I'll just pass on to Shaowei now.
Thank you for that wonderful leadway to the conversation that I want to set the context for today's conversation. I really appreciate this opportunity to be able to chime in, to share my thoughts and my experiences over the years during my teaching in the professional PharmD program. Next, please. So I want to set up the context of our today's discussion within the shortage of healthcare professionals faced by the U.S. healthcare system post-pandemic. And we have heard a lot of stories, I personally heard a lot of stories from my students, from my peers, that pharmacists are just to jump in wherever and whenever they're needed to deliver vaccination, be it in primary care clinics, in emergency rooms, or in the local medical centers. They are there with the patients, with the team members. And I think this really is this epic time that heightened the need, that call for participation of clinical pharmacists in the patient care delivery and on the team-based care. One of the aspects of the culture of the U.S. healthcare system, as I observe, as I have lived in China and in Beijing, China, and in Tokyo, Japan, is this. There is some subtle differences, but I would say is more evident and obvious to me that it's very patient-centric in the culture of the U.S. healthcare system. This reflected not only in the decision-making process, but also in the performance matrix, right? For example, our patient-centered medical homes, oftentimes they use this team-based interprofessional care model and bring physicians, nurses, office staff, technicians, care coordinators, community services. They bring all these people together, and all the patients actually have this, a primary care provider to coordinate all the referrals, follow-ups, and management activities. And a recent study showed that within a 12-month period of time, the average number of physician peers in the context by a primary care doctor is about 229 other physicians over 100 different practice settings. So this increased demand for attention and time of primary care physicians really exaggerated this unmet needs and care gap for our patients' needs of safe, effective, and affordable treatments, affordable medications. And in earlier slides, Katie really alluded to this suboptimal medication use. And these suboptimal medication use they really highlighted the need for clinical pharmacists step in, be able to address those missed treatment opportunities, the misuse, overuse, and underuse of medications. That leads to really negative consequences of health outcomes and skyrocketing healthcare system costs. Next, please. So many of you maybe know that before I was awarded this T32 Research Fellow with the University of Colorado School of Medicine, I have been teaching in the past 6-7 years in the professional PharmD curriculum, and particularly in the social, economic, and behavioral domain of professional PharmD curriculum. And I know the PharmD curriculum is very rigorously designed to connect between those basic biomedical science, clinical science, and administrative sciences to really prepare our pharmacy graduates ready to deliver cognitive medication therapy management services and direct patient care. And I know my colleagues and my students, they are ready to join the team and step up to the challenges. Next, please. So I think today's conversation will really be able to shed some light around the issue of reimbursement as a barrier to expand clinical pharmacists' professional roles on the team. Our U.S. healthcare system is a mixed payment model of both public and private payers. This hybrid payment system is different from many other international countries, such as UK, German, and countries in Asia like Japan and China. And more succinctly, if we look at this hybrid payment model, we have a value-based payment that increasingly kind of taking over and happening in many healthcare settings. And this value-based reimbursement model is really anchored on the improved quality and outcomes and cost reduction. It pays for the overall patient outcomes and quality of care measured by, oftentimes a comprehensive matrix such as readmission rate within 30 days of discharge from hospitalization, and the survival rate of certain medications within a certain period of time after surgery, the medication adherence, and blood pressure control outcomes. And we have fee-for-service reimbursement model, which is pay for separate services provided by qualified health providers. And our system is both, it's mixed of both. And I'm aware recently there's some backward movement in terms of the pharmacist incidental to billing. And I'm hoping that our today's talk will inspire and brainstorm tools and practical strategies and a mindset how to navigate around this issue to be able to, really elevate and empower all the members on the team, including clinical pharmacists. Next, please. So our paper, Integrating Clinical Pharmacists into Team-Based Care, in this paper, we laid out 8 pathways that clinical pharmacists can readily participate and contributing to direct patient care. I won't go into details into those specific examples, but this article, if you haven't had a chance to go into details, it's a worthwhile reading, and bring a notebook with you and take plenty of notes, because it's packed with a lot of practical tools and where to start with particular medications, particular patient populations, and those at risk. These are advices from a deep-rooted primary care doctors from his practice site. So it for sure will accelerate your path to establish clinical pharmacists as a drug specialist on the team to educate and advocate for patients' optimal medication use. And we will leave some time for Q&A for those specific examples at the end of this. At the end of our presentation, because the stage is really for you, for the audience to chime in, to really having those open discussion and brainstorm. Next, please. I want to chime in and really emphasize a less discussed aspect of population health. So population health, I think, is the future direction of clinical pharmacists can really expand and really to deliver more impactful interventions to address certain population at a higher risk of those complications of complicated medications and long-term serious chronic illness. One example is those factors contributing to the non-adherence and suboptimal medication or even overall health outcomes is social determinants of health, right? For example, food insecurities are a precursor to competing needs of medication use. And oftentimes food insecurities leads to adverse drug events, for example, hyperglycemia, and our clinical pharmacists are well positioned and well equipped to address that. Many of our patients, really suffer low health literacy. They don't know what and why and how the medication is used. This leads to those missed treatments opportunities, and which can spiral into much worse situation. And pharmacists can really breaking down those language barrier and educate them with plain language. So as a pharmacy educator and putting my educator hats on, I know a lot of clinical pharmacists and my pharmacy students, they are well equipped and trained, having this foundational knowledge and skills to be able to offer some innovative and creative solutions for these challenges we have seen in the healthcare system, and particularly in the population health arena and related to health informatics. And here we like to open to more discussions and welcome questions from our audience.
Shaowei, I'd like to ask you a quick question. Our article focused a lot on how practices can integrate clinical pharmacists. But what advice do you give to your students regarding what they should look for in a practice?
What they look for in a practice? That's a really good question. So oftentimes, because I'm in the administrative on the softer side of clinical practice, right? So I talk about culture, I talk about vision. So I oftentimes would encourage my students really to get to know the clinical practice a little bit better, know their mission, their vision, and what's the patient population the clinic is primarily serving, and what they can bring, to the table. Who are they going to work with? Physicians and nurses, the scheduling staff and care coordinator and social workers, and how to really build in those network to connect and really enhance the value they can bring to the team.
I think it's really important, that last point, which is for pharmacists to know their value. I think one of the really heartbreaking things I see sometimes in practices is that practices do not know how to integrate clinical pharmacists, and they have them doing menial or trivial things. And I just want to say, if you're involved with pharmacists in your practice, please don't put them in charge of samples, closets, or prior authorizations. That's working well below the tops of their licenses. And for pharmacists who are considering joining groups, get at the heart of that. Are you going to be included in the valuable points? And to go straight to it, you want to be at the point of clinical decision making. And for pharmacists, that means at the prescribing point. Really, so much more than following orders or doing supply management. And I think that's when you think about, where do I start? Where do I show my value? It's at the point of prescribing.
So, Dr. Teichman, first of all, thank you both for your terrific comments opening. But we'd love to hear from your standpoint what the three most important things that need to change in primary care to truly embrace a collaborative care model that both of you have discussed. What are the things that need to change in order for that to occur?
Well, the first directly reflects the slides that you started with in terms of just the lack of awareness of capabilities of clinical pharmacists. I have met so many doctors, nurse practitioners, and my colleagues, even in my own clinic, who are unaware, A, that we have a clinical pharmacist, and B, what all they can do. And when they see what the clinical pharmacist is doing with me, they're amazed. And they have this question, can you do that? And I say, of course. So once they start learning that, then they refer far more patients to the clinical pharmacist, which is not so great for me because then I have to share more than I want to. But so number one is getting a clue of what clinical pharmacists do. I go back to that statistic, that number 4 years of medication management. None of us can compare to that. The second is a mindset change for clinicians such as myself, which is we don't own the evidence. We don't have a particular expertise in everything. And I tell my clinical pharmacists, because it's true, that there are many things you do much better than I do. I would trust you far more than myself about managing the newer diabetes medications. They're just really new, complex, expensive. Finding an affordable pathway that patients can tolerate is difficult, and I don't have that skill set that you have. So share the access to knowledge. No one owns it. It should be shared broadly.
And I think that's part of the philosophy, the interprofessional team that both of you have outlined. And I'm sorry, I didn't mean to interrupt you. Go ahead.
Right. Yeah, and the third thing is simple nuts and bolts of practice. If your clinical pharmacist is just being shuffled around to whatever space is available for the day, or working out of a small office, or doesn't have support staff, they are going to fail. You need to respect what they do, which means giving them plenty of physical space, dedicated space. They need to have clerical support. If they don't have clerical support, they're going to provide the clerical chores. Clerical chores take a long time. If you think it's worthwhile to turn clinicians into clerks, you're not going to do well with this. Know the full capability of your clinical pharmacist. Treat them as the full clinicians as they are, with staffing, scheduling support, office space. Then they can thrive.
Thank you. I think those are all very good points. Dr. Wan, your article points out that much of the time clinical pharmacists spend with patients should be involved in discovering more about the patient's lives and integrating those findings into the care plan and the medication plan. Can you describe a typical patient encounter with a clinical pharmacist working in collaborative practice with the primary care physician?
So if my colleague were here, I would direct this question to her. Or, over the years, I've worked with many excellent pharmacy practice faculty members, and I think that a clinical encounter between a clinical pharmacist and patient is really very similar to a clinical encounter between a physician and a patient. So upon patient entering the clinic, right, and pharmacist will greet and introduce him or herself. And of course, those, vital signs and family histories, they are probably gathered, right, upon entering the clinic. And I think a instrumental role of clinical pharmacist is to really be able to asking the patient to bring a list of medications they are actually on, not they think they're on, right? And be able to really start to gather the list comprehensively and really evaluate them against their own repertoire of knowledge and guidelines, and really providing an assessment of what needs to be changed and make justifications accordingly. I think this really speaks to this pharmacist-to-patient care process, and I think that truly lays out really small steps, how clinical pharmacist cognitive services can really be, embedded in the patient flow of a typical practice clinic.
And Dr. Teichman, how do your patients respond to that? I mean, you have been working in collaborative practice with pharmacists, as you've mentioned. How do your patients respond to that?
They usually like her more than they like me. I'm doing a lot of things in a visit. There is agenda overload in primary care. We do spend more time with patients nowadays than we did in the past, but the number of things we're covering has mushroomed. Mm-hmm. So when we have the opportunity to focus on a specific issue, especially medications, that just washes the patient in attention about a really critical area of their care. And when they come back to me later, I always ask them, how did it go? And universally, they said she was great. She was very professional. I didn't know she could do that. To me, it's a real halo effect I received from the pharmacists. Overall, pharmacists are the most trusted profession in our nation. Surveys for years and years have shown that. And if some of their shine can be shared with me, I really like that.
Well, you definitely, Holly, I'm going to introduce you now. You definitely have a physician champion within the practice that you work. Joining us on the call today is Holly Christian, PharmD. She received her PharmD from North Dakota State University, and she did her residency at the University of Minnesota in ambulatory care. And we are certainly familiar at the Institute with all the wonderful work that's going on in Minnesota. But she currently serves as a clinical pharmacy specialist with the Sante Physician Partners. Holly, we would be happy for you to respond to any of the comments made by Dr. Wan or Dr. Teichman.
Yeah, absolutely. I mean, I appreciate the kind words from Dr. Teichman. I love sharing the patient load and helping take some of that burden off of my providers that might not have that specialized information about even different formulations of medications, what are available, and kind of giving that insight, especially for cost of medications or barriers that patients are experiencing, that sort of thing. I echo exactly what Dr. Wan and Dr. Teichman have already said, that a lot of times in my practice, even in the different clinics that I'm integrated in, many providers are not aware of our specialty. And I ask them to kind of consider us as if they were referring to any other specialist, right? We just happen to be located in the physical clinic, and our specialty is medications. And so it's an evaluation of, is the medication indicated? Is it efficacious? Is it safe? Are we getting the most bang for your buck for a patient? Basically asking them to evaluate all of these medications, or even a specific one if we want to focus in and say, are we getting the most that we can out of these medications if we're choosing to use them? And then just to echo Dr. Teichman's barrier, or addressing a certain barrier, is the logistics, to be honest. I don't have a specific team that works with me, like my own medical assistants, things like that. So sharing those resources is vital in order to getting a streamlined practice for integrating the pharmacist. So we've got a really good system worked out for Dr. Teichman's team, where, you know, his MAs just know if he's going to refer to me for a specific medication, that the patient gets the appointment with me the minute that they're referred. And they usually get one within the next couple of weeks, which is pretty rare for specialists or referrals in general. And they have the liberty to schedule, they have the liberty to change those visits, and to even introduce what the visit is about. Because a lot of times for medical assistants, they're pretty darn close with those patients as well. They know, they do the roomings and that sort of thing. They know when a patient doesn't know their medications. And so they also know when a patient might benefit from visiting with a pharmacist, because they might not know exactly what they're taking upon check-in. So I just kind of echo everything that Dr. Wan and Dr. Teichman have said about integrating a pharmacist into the practice, and how beneficial it can be for everyone, to lighten the load for the providers, and then to also explain some of the inner workings of medications to the patients as well.
Thank you. And Dr. Teichman, I know your personal interest in a lot of the work that you have done has been around health information technology. And we know from an institute standpoint that making sure that clinical information flows to the point of care for the teams, for the interprofessional team, to include the clinical pharmacist. What type of infrastructure do you think needs to be set up in order to not only make the referral so that could be responded to quickly, but also ensure that those team members are adequately prepared to deal with and manage the needs of the patient?
Right. So two things that Holly said I think should be emphasized. One is that as close as you can time-wise to determining that you're going to make a referral, getting the referral done. There's a lot of drift in referrals. The longer people are set out, the less likely they are to keep the appointments. And let's face it, if it's important, it should be done quickly. I really love that rather than waiting for an endocrinology appointment to pop up 3 or 6 months down the road, for diabetes management of complex cases, we can refer pretty much internally within and have the patient seen within 1 or 2 weeks. It makes all the difference in the world. We do not want people walking around with blood pressure, blood glucose out of control. So that closeness of knowing where your pharmacist is physically nearby is important. The second is get the referral done quickly, the internal referral. So when you make the connection, you tell your patient you're going to do the referral, you tell them why, you hand that off. I hand it off to my medical assistant, who then schedules directly on Holly's schedule. So it's done before the patient leaves, which is very different from many other referrals, which I say, yeah, if you don't hear back from that cardiologist in 2 weeks, please give us a call so we can track what happened. So it's smooth, it's easy, and it works better than any other referral. So you already have the infrastructure. It's just a matter of being confident in using it.
Now, Dr. Wan, if a clinical pharmacist is interested in working with a primary care practice in the manner in which we've described, what are 3 important things that they should consider before approaching that practice? What are the things they need to be mindful of in approaching that practice?
So this is kind of, this question actually is a little bit similar to what Teichman actually, Dr. Teichman immediately after the slides kind of imposed that kind of question for me. You know, I think putting my pharmacy educator's hat on, I think, you know, in addition to the knowledge and skills which our pharmacy students have been well trained in the 4-year rigorous curriculum, I think is having, you know, and having those, you know, soft skills of communications, of marketing tools, that they are readily available to advocate themselves and assert themselves in the team-based care. Right, to that includes, that translates to understand the mission and the vision of the healthcare system, understand how to communicate with their team members, and know how to really be able to demonstrate, you know, the value, and really be able to manifest that value in a way that is evidence-based, that is readily be able to incorporate it into, you know, the daily decision making, you know, including those, you know, tools and checklists that, you know, pharmacists are well trained for. There are, you know, a lot of tools, you know, in the PharmD curriculum, we kind of rehearsed and coached our students to be able to, you know, equipped with, you know, like those AHRQs, health literacy tools, and you know, those readily available, those, you know, blood pressure and bleeding risk factors and atrial fibrillation kind of evaluated tools that they can bring immediately to the practice.
So we have a question in the chat. Someone wants to know if you guys feel that a pharmacy residency is necessary in order to provide these patient care services at the primary care level. Be interested in all of you, Holly, Peter, and Shaowei, response to that.
I'd like to hear what Holly thinks.
That's a tricky question to answer, because I don't think you necessarily need a residency to do what it is that an integrated clinical pharmacist is doing. However, I will say it has advanced my practice exponentially. I probably wouldn't be where I am right now without a specialized residency. My PGY1 was in family med, and it provides just such a specialized view of finding those medication solutions that sometimes you don't get in other locations, or working at retail, or jumping straight from school without a residency. Now, some of the residencies don't have a specialized focus, or they don't have even a longitudinal focus or rotation where they are practicing in an integrated setting. They're doing rounds at the hospital, and that might be a different type of residency that you might not necessarily need. But clinically, you don't need one, but it certainly helps.
I think you definitely need residency to do this work. And part of it is, if you look at what someone like me's done, I came out of medical school, but no one would dare trust me with patients. I had to do 3 years of my specialty training and get my skill set up. I think that the schooling side of it is like learning a language, and the residency side of it is learning the culture. And when pharmacists move forward and can bill for services, it's going to look a lot like what it did for doctors. you had to be board certified. And to be board certified, you had to have additional training. You have to pass exams. That assures our patients and the public that they're getting value. And we need some sort of indicator of what that is. Maybe residency is not the best indicator, but it's the one available. And I think that I feel much more confident knowing that our clinical pharmacist is residency trained. And I think that's going to be one of the distinguishing features. There's a schism in pharmacists now. Many go into retail, and I think the future of retail pharmacy is going to be one of robots more than people. As we get more algorithmic in our approaches to care, we need people who can deal with nuance. Algorithms try to remove the noise from the system. Primary care is treating the noise. It's what Shaowei was referring to in the social determinants of health. Those have huge impacts on the decision-making about prescribing. And you need to be able to integrate that. And I see the skills of that are much more available to resident trained pharmacists. I know Shaowei's dog had something to say on the matter too.
Well, the good thing about Zoom is it introduces real life to all of the professionals out there. So I think we recognize that, and those of us that are dog lovers both appreciate the sound of that bark and embrace it. So Shaowei, do you have any comments you'd like to make as it relates to the residency question?
Yeah, thank you. Thank you for the support. It's a team. It takes a village. You know, as a pharmacy educator, I really value, you know, what we have already taught and the components we have designed and structured in the PharmD curriculum. Like Dr. Teichman, you know, summarized, is residents, right? Resident training is like medical school residency training is one of the hallmark of medical education and for physicians. So I think what I wanted to say is, you know, our pharmacy graduates, they're on the spectrum of developing their skills. And I think, you know, residency training is one of the pathways to get there. And many of the pharmacists that they are taking, you know, their own way, you know, there are a lot of ways to get to Rome. They're emerging from community pharmacy. They are, you know, taking challenges, you know, right off the graduation, if there is a calling for them. And I've had students who, you know, very capably and taking those challenges. So for me, I think it really has to, you know, really looking at this market demand and look and really engage the market needs of at the time. You know, if I was a pharmacy student, I would have really looking at the market needs and really engage in those opportunities rightly available to me first. So this is not against saying, you know, maybe I will planning on the resident application and training, you know, further when there's such need emerge that really will well rewarded, you know, professionally. And I think that's the approach that I would take.
All right. Well, we've got some good questions that come in from the audience, and I'm going to intermingle some of our discussion questions with these good questions. So let's turn this a bit to application in terms of operationalizing these services within the practice. In your article, Dr. Wan and Dr. Teichman, you outlined 3 prerequisites for working with clinical pharmacists from medium to large medical groups. And those 3 areas were collaborative practice agreements, electronic health record capacity, and scheduling support. And I think you've outlined many of those areas in some of your opening comments. But we have a lot of questions around billing and how to ensure that in looking at establishing the service, you have a business model that will support the service. Can both of you make a couple of comments about billing for these services and what your experience has been in that area? And then Holly, after they've responded, feel free to chime in as well. So, Dr. Teichman, we'll start with you.
Oh, sure. Well, we have to tread delicately because this is an evolving issue. United States healthcare system is a non-system. We don't have a set of guidelines that everyone follows. Every insurer takes a different approach to payment, and the approaches change over time. The overlord, if you will, is Medicare, CMS, and they may make determinations of how they're going to do things, and they can change their minds. So I think they will change their minds soon about this because they've been changing their mind back and forth on this for years. But though in many areas, the other private insurances or state insurances have followed Medicare, my experience is that they don't so much in this. So currently, pharmacists cannot bill the higher levels of services, say 99212 to 99215, which is what I bill when I see patients. They cannot bill those as incident to and be reimbursed under Medicare. That has some shifting around because Medicare is not one monolith, it's regionally administered. And in some areas of the country, Medicare has honored some of those billings. And basically from 2014 to 2018, that was an acknowledged incident to billing. The final decision that came out a couple years ago, and if you'd like to read 300 or 400 pages of details on that, you may, said no. I think that we will probably see that change. So we find that individual insurances do cover 99212 to 99215. It's quite variable. There are some medication management billings that a few insurers do, like our county insurance covers that. There are individual things that our clinical pharmacist excels at that we can bill for, like alcohol dependence management or tobacco cessation. So we can do additional billings for that. As I said, it's a situation in flux. It's a area that is delicate, but on the provider side, my personal viewpoint is I'm agnostic. If my patient needs the skill set and can benefit from our clinical pharmacist, I'm not looking at their insurance. I'm sending anyone their way. I know that it's going to help overall patient care for our team and for everyone. So if we get paid for that or not is not my primary interest. I feel that there's other ways that we benefit and the service is absorbed and spread around. So I don't take a strategy of looking at a patient's insurance before making a referral.
Thank you. So for the sake of time, Dr. Wan, unless you have anything to add to that, I'll go on to another question just to make sure we had some of these wonderful questions in. Did you have anything you wanted to add to that?
I think that's definitely a key barrier, like we discussed earlier in the paper. And
okay.
I have no more.
Okay.
Concrete.
And I think you do a good job of discussing that in your paper as well. How do you, Dr. Teichman, how do you select patients that need to be referred to the clinical pharmacist in your day-to-day practice? That's the first part of the question. And then the second part of the question is how do you establish your ratio of pharmacists to providers? Because both of those are intermingled there.
Sure. So there are a few conditions that I just always refer. When I'm confronted with a legacy patient who is receiving multiple opioids or opioids and benzos or opioids and Z drugs, and they've been on it for years, and now, I mean, that was never safe at any age, and yet now they're aged, they're elderly, that is just bad news, difficult stuff. And the patient's interest in changing it varies between reluctance to full resistance. Very rarely do we have patients that say, oh yeah, I'm willing to give up that Xanax 3 times a day and the OxyContin. That's a dangerous situation. The medical boards frown on it going forward, and we're doing a mop-up on that. So it's just too difficult to take that on by myself. We don't have high access to pain management. There are a lot of barriers for patients there. So I definitely reach out to clinical pharmacists in those situations. And the patients don't like hearing from me about starting on tapering plans. They don't like hearing it from our clinical pharmacist, but it's sharing that load, and it makes a huge difference. The other things I almost always refer my willing patients who are overusing alcohol and tobacco. You know, in your slides, you've done a fantastic job of looking at the harms in inadequate treatment. And I would say the two most undertreated conditions are nicotine dependence and alcohol dependence. They do so much harm in our society and to individual patients and to families and to communities. And there are effective treatments. There are effective treatments. So I can get the ball rolling on that. I can decipher what the patient's interest is in tapering or stopping, and then I can pass that person on. And Holly just does a fantastic job with those folks. And, you know, they don't always get much better, but plenty of them do. So those people almost always go to clinical pharmacists. The rest is a total hodgepodge. And, you know, primary care, family medicine is just teeming variousness. Our number one diagnosis that we make is nothing, everything. So every day I'm throwing something different towards our clinical pharmacist. And fortunately, she has not yelled at me about that.
So from a staffing ratio standpoint, is there a way that you determine what the staff ratio should be of clinical pharmacists to primary care physicians, or is your program evolving and that has not been a process you've gone through yet?
Well, I'll let Holly follow up on me, but I could use myself, a clinical pharmacist, pretty much by myself. But in our healthcare team, our clinical pharmacist is shared amongst several practices. And I'm imagining that's around 10 to 12 doctors and probably 8 nurse practitioners, physician assistants. Is that right, Holly?
Yeah, it ranges from 10 to 12 to maybe 15 with the additional clinics that will get added, and then various nurse practitioners and physician assistants, that sort of thing. And each one, to be quite honest, will have its own preferences for referring. So like Dr. Teichman said, he'll send me a full spectrum of patients that I get to work with. And oftentimes those collaborative practice agreements that we have in clinic are encompassed by a general one that says if the provider requests our services, we can do a complete medication or a comprehensive medication review. And then I have providers that will refer for the patient that has tried, 2 or 3 specific blood pressure medications, and they just cannot seem to figure out which one is going to work for the patient and which one they're going to take effectively or consistently. And we'll get those specialized ones too. But in general, we have collaborative practice agreements for a number of things, which allows me to do the review, to do the assessment, order the labs, change the medications, change the doses, switch therapies for specific cases. Anything that falls outside of those collaborative practice agreements, it usually falls into a comprehensive medication review. And if it's outside of what I feel comfortable doing, or if it's outside of my spectrum, I will always ask for that referral back to the provider, ask for the opinion back to the provider, say, this is what I'm thinking. How do you feel about this? And we bounce it back and forth. So it truly is a team effort, but it ranges.
Thank you, Holly. We could talk all afternoon about how you structure the collaborative practice agreements, how you've overcome barriers around health information technology and ensuring that you have a complete medication record. But unfortunately, our time has come to an end. Dr. Teichman, I'm going to ask you and Dr. Wan to give us a final comment and a final word before we wrap up today, and hope that you will continue to support this work, both Dr. Teichman with your support through the Physician Advisory Board that you're on, and Dr. Wan through the work that you've done from an academic standpoint as well. So, Dr. Wan, I'll start with you and ask you to offer a final comment or words of wisdom as we look from the Medications Right Institute at advancing access to this level of service. And then Dr. Teichman, I'll ask you to do the same, please.
I think this word is really for, my students that I've taught over the years. And I think for you, is to be really confident and assertive about what you can offer to the healthcare team. I think you have all the foundation and training and skills to really put yourself forward, right? And to be this change agent, breaking down the silos of the healthcare team's culture, and to really, start to educate and really talk about medication use, with your patients, with your peers.
Thank you, Dr. Wan. Dr. Teichman?
Whether you know it, your colleagues know it, your practice manager knows it, or the CEO knows it, pharmacists have wings. Fly with them.
Thank you so much. And on behalf of the Get the Medications Right Institute, I would like to thank our speakers, Dr. Teichman and Dr. Wan, and the audience for joining us today. Please fill out the survey that you'll receive at the end of the session today. And to stay up to date on the Get the Medications Right activities, make sure you join us on Facebook, LinkedIn, and Twitter by searching for GTMRx Institute. Again, thank you for joining us today. And until next time, be well.